Good evening, everyone. Welcome to yet another session of e-Gurukul, started by Dr. Yogesh Parikh sir. We had a short break in between, but from last Saturday, we have started the sessions again. And I think it's been benefiting the PGs a lot with all the interaction with experts whom we get for every session. So for today's session, we have Goa Medical College presenting a case, and we have two experts for today's session. So I welcome Dr. Mahadev Swami, who is an MD, DNB, Clinical Hemato-Oncology and Bone Marrow Transplant, presently working as consultant hemato-oncologist and bone marrow transplant at Manipal Hospital, Goa. And our second expert is Dr. Ankit Parmar. I think sir is yet to join. He's a MD, FNB, FIAP pediatric hemato-oncologist from Wadia Hospital, Mumbai, and currently working as consultant pediatric hemato-oncologist at South Gujarat Hemato-Oncology Center, Surat, and also a visiting pediatric hemato-oncologist at Thalassemia Center and Major Hospital, Surat. He's also written books of thalassemia and sickle cell management, as well as pearls of pediatric hematology. So I welcome both our experts. Welcome, Dr. Baldev Prajapati, sir. Thank you for joining in. Welcome, Dr. Nehal, ma'am. And I think, should we proceed with the session? Can Dr. Aijana start sharing in? So we have Dr. Aijana, our JR, presenting the case. And we have Dr. Anili, our assistant professor, as a mentor.
Good evening, everybody. Hereby presenting a case of Anurag Herge, 4-year, 6-month-old male, resident of Sangam, South Goa. Second child born out of non-consanguineous marriage. Informant being mother reliable. Chief complaints. He came with history of fever since 1 day and history of noticing pallor since 1 day. Patient was apparently all right 1 day back when he developed fever, which was low grade, documented spikes of 100 to 101 degree Fahrenheit, intermittent, recurring approximately every 8th hourly, associated with rigors, which subsides with medications with no diurnal variation. So, and also there was history of noticing pallor by the mother over the oral mucosa, palms and soles since 1 day. History of noticing cola-colored urine since 1 day, which is more during the early morning sample and gets cleared by evening. No history of any decreased urine output. There was no history of any burning micturition or painful micturition. There was no history of black tarry stools. No history of bleeding from any sides. No history of any diarrhea. No history of pain in abdomen, pain in the limbs, or any convulsions. No history of pica. No history of passing worms in the stools. No history of persistent cough. No history of blood in stools. There was no history of any recent drug intake, no history of any bony pains, no history of breathlessness, palpitations, no history of irritability, temper tantrums, or breath holding spells. In past history, there was no...
Can you just stop sharing for a while? Because as mentioned, suppose if you are sitting in the OPD in our outdoor department and this child comes to you. I think what she mentioned, that 4.5 years old male child, history of only 1 day duration. And that's what she described, that the fever, then pallor, and your mother noticed some cola color or dark colored urine. Suppose if we take first two complaints, the fever and pallor, forget regarding the third complaint. Third complaint will incorporate the discussion later on. Dr. Rajat, how will you take it? Suppose the mother comes to you directly, that 4.5 years old child, fever for a day, and probably because she made the complaint, there must be significant pallor. So what type of problem will come to your mind? And she has mentioned the duration also. The pallor of only 1 day duration. That means within a very short time, mother has noticed. Anybody else? Even Virat can take. Please take whatever comes to your mind.
So in the background of fever and cola-colored urine, it can be one glomerulonephritis.
I think forget the cola-colored urine. First, let us take the only 2 complaints. Then we'll add the third one. Suppose fever and significant pallor, and that too within the very short time, in a day or so, because the way in which she has presented. Then what will come to your mind? Then we'll go to the various points to understand the situation. Yes, Dr. Virat, can you take it?
Fever is a sign of infection. So any infection differential you want to say?
Sorry, I could not locate. Who is contributing?
I'm Dr. Mahadev here, sir.
Okay, yes, sir. Please carry on.
Very short history. Fever, 1 day fever.
Yeah.
I'm audible. I'm audible, sir.
Yes.
Yeah. It's very short. Only 1 day fever. So fever is a sign of infection. So I mean, I'm just asking the leading questions from the PGs whether we need to keep some infection etiology in the mind the first rather than directly going into the cola color. As mentioned by you, we go with only 2 points, fever and pallor. So what are the things comes in our mind?
Complicated malaria can be one possibility.
Okay, very good.
Yes.
Very good. I will appreciate that this thing should come to your mind first, and which is common even. Fortunately, since last few years, malaria is down, but it is not totally out. And naturally, this thing will come to our mind. The fever, what I think Dr. Madhavya is a hematologist, am I right? I'm able to locate it properly?
Yes, sir.
Yeah. Then, the sir can give the hints in a very easy way. And suppose if we consider in the reference to some fever and there's some infection and sudden pallor, then probably that can be, as Dr. Ajna mentioned, that can be the complicated malaria, of course. But suppose if it is malaria simple, malaria is not complicated, only PVX, and it has not even presented in the form of the complicated malaria. Some associated problem with the child caused severe pallor. What it can be? Some hematological condition was there, which was not diagnosed, which was not known to us. But the child developed fever, it was malaria. Yes, Rajat?
G6PD deficiency.
Very good. I think these things should come to our mind. That the child has, we don't expect that much, I would say, pallor significant, except some complicated malaria. And suppose child is walking, not that bad, no other features of complicated malaria, but still significant pallor, severe anemia, then I think this should come to our mind. And suppose male child, we'll suspect very strongly that maybe the G6PD, and that we can keep in mind. Anything else?
So it can be underlying any sickle cell disease with acute onset of febrile hemolytic reaction in sudden pallor.
Okay, I think that is also one of the points you may consider, that already it was going on, hemoglobinopathy, fever may be due to malaria or viral or anything, and probably it might have caused some problem. Okay. I will give you another case scenario, that this was the 6-7 years old child. Child had the fever, very mild, but very bad cough. And not, I will say, significantly tachypnea or so. Mild tachypnea was there. On auscultation, some wheezing and even the crepitations. That too also not significant finding, but yes, findings were there. And chest X-ray showed some haziness or scattered opacities, which somebody said that it is pneumonia. I started this standard protocol antibiotic. Patient was not responding, and child developed sudden this drop of hemoglobin. Can you locate what it can be? It's a respiratory problem, if I draw attention. It started with fever and cough. Cough was very bad. Rather than, in pneumonia, on the contrary, breathlessness is more common. Somehow your cough was bad. And child was showing some chest signs, radiologically suspected some, not exactly the lobar pneumonia, but scattered some opacities. Count was normal. And suddenly the child developed drop of hemoglobin. Suppose previously I have done, which was 9 gram or 10 gram, but now it has come down to 5 to 6 gram. So that means what can be the reason? Are you able to locate some infection again? Respiratory infection, which can cause this type of the picture, where the pneumonia is there, but patient is not that bad. Cough is very bad. Minimal chest signs. Radiological, not this exact picture, but yes, showing some viral pneumonia-like picture. Count was not high and caused a drop of hemoglobin. Any idea?
So which infection causes hemolysis? That's what a sir want to ask.
Yeah, as sir is giving the hint that this drop of hemoglobin and sudden drop of hemoglobin in this type of the situation, always think for the hemolysis. Now sir is asking that it is pneumonia, organism is causing the pneumonia, and which one will cause this? Yes, Dr. Kundan has put Mycoplasma pneumoniae. Absolutely right.
Very good.
I will say this is not so uncommon, may not be our daily practice, but yes, we do come across. So we can keep in mind. Now coming back to our patient. Fever and this pallor, now add the color of the urine. Then probably our thoughts will be getting changed. It will be narrowed down. Already we kept in mind in this way that fever and pallor, that means it is due to some hemolysis. But now that hemolysis has caused this dark colored urine, cola colored urine, then what it could be? What does it indicate? Please,
Intravascular hemolysis.
let me make the point clear. Our case is the example. We are not interested only in the case. We want to learn as a whole, different situation, different conditions. Right? So now, what will be your thought? What happened? Or what type of hemolysis which caused this, even the cola colored urine?
Say intravascular hemolysis.
Okay, very good. Then what it could be the cause? Can you think some cause? Is it pathology rather than cause? Always I will give the idea in any case that first try to think that what type of the, what is the anatomy? That means really RBC problem or some other problem. Suppose RBC problem, then think that it is what type of problem? Loss of drop of hemoglobin. So it is due to some blood loss or really due to some even nutritional problem, or really something is wrong with the RBC. And that RBC also, whether it is the structure or somebody is causing the more destruction of the RBCs. Try to think in this way. Here, I think if we take in this way that fever and the pallor, already we thought of that this hemolysis should be there. But that hemolysis caused this cola colored urine. Right? That means intravascular hemolysis, agreed. But what type of the mechanism or pathology will cause this type of the acute problem? I will say, it is so acute that within a day, not taking even much time. Then which type of the disorders can cause this acute hemolysis? Keep in mind, already we discussed, number one is the blood loss. Suppose some history of injury, trauma, blood loss can cause the severe anemia. Second, that even it is due to some particular even hemorrhage can be in a case of portal hypertension. Then also it can be even in the newborn hemorrhagic disease of newborn, that also can cause the blood loss. Right? Or what these type of the regions will cause, that means loss of blood. If not loss of blood, then there should be hemolysis. Hemolysis also can be due to the various regions. Already once very nicely all of you discussed that complicated malaria. Yes, that can cause the significant anemia. within a very short time. What are the other mechanisms where even somebody called G6PD deficiency? Absolutely right. Or enzyme deficiency, and even pyruvate kinase, not so common, but that can also cause it. And what is the another mechanism where it was this type of the sudden drop or destruction of RBC is possible? Anybody?
So RBC membrane defects.
Yeah.
Okay. Yes, Rajat, continue, please.
So defects in the RBC membrane, if, for example, hereditary spherocytosis or
Agree. But do you know that the hereditary spherocytosis will cause the hemolysis so rapid? Here it is in a day. What I mean to say, acute hemolysis, sudden hemolysis, loss, yes.
Hemoglobinopathy, sir.
Then even
Like
already we
sickle,
discussed that malaria can cause it. Yes, Ajna?
hemoglobinopathy is like sickle cell anemia.
You know, sickle cell and other things, they are known for this some crisis. Not this type of this sudden drop. Of course, it can be due to various reasons. Even suppose sequestration, it can cause it. Please remember, any disease process, if you think acutely or hyperacute, that means, within few hours or days. If this type of the disorder it is there, any system, I will say, it's an immune system. Suppose if you take the anaphylactic reaction, it develops very rapidly. If you go for even any immune disorder that can present in our bronchial asthma, the patient was well and immediately comes back to you with a very bad presentation. So immune mechanism. Now suppose if you think over here for the immune mechanism, what immune mechanism we will keep in mind? Come on.
Autoimmune.
Okay, one is autoimmune, which is known. Autoimmune hemolytic anemia can present in this way. Any point supporting to you to say autoimmune hemolytic anemia in our case, Ajna? Any strong point which you can say that, yes, this is supporting me to say autoimmune hemolytic anemia?
One is the acute onset of...
Very good. One is the acute onset within short time. That is common, I will say, on presentation. Anything else?
And the
Dr. Viraj is there, but putting on the chat box. Viraj, I think you should speak, please. That what happens that we can speak in the exam also. Anyway, your comments are good. Age of the patient. That what is it is common, autoimmune? Viraj, can you put it? Because you have put the age. Anyway, any immune disorders commonly, usually after 4 to 5 years, immune disorders. Right. So, of course, you can consider. Very important point, fever, presence of fever. If not infection, immune mechanism is possible. And third point, very important, is the cola colored urine. So I think from this we can keep in mind that even it can be the complicated falciparum malaria or even G6PD deficiency or autoimmune hemolytic anemia or probably this type of this son developing acute condition. Now, I think before we go further, let us take the help of Dr. Madhav Swami. Please, can you add the points which you would like to put that here we can discuss in some area also? Doctor, please.
Sir, here everything basically boils down to history first. Since here the history is short, so as mentioned by Baldev sir, ki acute is kept in our mind as of now because one day history, one day complaint. And since there is a fever, some mind tends to boils down to the infection component versus immune component. And since the third point has been added here as a cola colored urine, so that boils down to again there is something happening intravascularly, something involving the kidneys. So which acute condition which will address all these three, fever, pallor hemolysis and cola colored urine. So something we are dealing with intravascular hemolysis. That's what comes in my mind. So since it's a 4-year child, I mean, presenting as a fever. So, I mean, infection, I can't definitely take it out off from my mind. So someone mentioned mycoplasma pneumonia. Mycoplasma sometimes may not have a respiratory symptoms at all. Sometimes they may present with only systemic symptoms and directly coming with an hemolysis. Some entities called as cold agglutinin antibodies, where the hemolysis is predominantly within the vascular component. So that one I would like to add here. See, cold agglutinin disease we need to keep in mind where it is very much acute compared to the warm antibody type.
Thank you very much. Thank you. I think these
Yes.
are the things how we can think, and our point is how we should start our thought process. That is more important. Diagnosis is not important because diagnosis can be any. Again, I request, there are so many, I will say, friends on the chat box, sorry, on the screen, but somehow they are keeping their video off. Please come on, participate in the discussion very freely. We have, I will say, two learned, even the experts, and from their comments, even probably we can have the more interactions. Again, I'm sure that in the due course of time, they will do. Now, Dr. Anjana, you have mentioned so many negative points. What was your idea? Can you just take it, that what was your idea one by one within the short time? I think it directly come to you because I have taken the photo of when we are presenting so that I can remember. And you have mentioned that the decreased urine output. Rajat, you should answer. What is the importance? In this case, decreased urine output. Suppose here in this patient, it is not there, but it may be even. And she is expecting, and therefore she has clarified that it was not there. But what does it indicate? Due to what the decrease in output may develop? Anybody? Yes?
So
Tirumala, you can also speak. Please, any student. Kundan.
so basically to rule out glomerulonephritis or hemolytic uremic syndrome.
Yeah. Okay. I think in short, what simply, we do not know the condition. But we want to know, is there any point indicating, suggesting cranial involvement with a reference to the decrease in output? That can be due to various reasons, not only due to the glomerulonephritis. Suppose even due to the hemolysis, on the contrary, with the hemolysis, what type of the kidney injury is known? With massive hemolysis, what type of the kidney injury is known? Renal injury is known?
Acute tubular
Yeah, tubular necrosis. And that patient will may present with sudden even renal shutdown. So valid. Burning micturition. Anjana, what was your idea?
Sir, with history of fever and passing cola-colored urine, so to rule out any UTI in the child.
UTI patient will present with a cola-colored urine.
Which is sometimes like the infection can also cause.
I will say not sometime, but not any time. Right. UTI is not expected to come with this cola-colored urine. Right. So that's why what I will say, don't invite the trouble in the exam by putting some points which may be difficult for us. Then black terry stool.
Hello, sir.
The idea of keeping the black terry stool.
So history of bleeding from any other sides, like if cola-colored urine is there, that is
Okay. Yeah. That means if clearly bleeding is there, bleeding from the other side. Diarrhea, okay. Diarrhea, what was their idea?
So in hemolytic uremic syndrome, there.
Okay. Pain in abdomen, and I think convulsions, some pain, same point of view. What are the, how is the history of pica is related over here?
So that was for like if that anemia, like the blood loss is causing so much anemia in the child. So
but do you expect that it will present with the acutely in 1 day time, and that to be the cola-colored urine? You know that with the pica, if you are expecting worms infestation, most commonly the ankylostoma duodenale, which will cause the blood loss, but it is a very chronic blood loss, right? And pallor, but not in this way. What I mean to say that always put the relevant point so that unnecessary we have not to give the explanation. Of course, passing worms in stool, same point, persistent cough, and again blood in the stool. So what was my point over here? That always put the negative points related to our case, from which probably the presence or absence of the point helps you to consider your diagnosis or to exclude some nearby differential conditions or presence of complication due to the condition. Right. So keeping in mind, go for the negative points. Okay, please go ahead. Sir, anything before we go, Dr. Nadeva?
Sir, I just would like to add, she
Yeah,
mentioned
please.
as urinary symptoms. As mentioned, urinary tract infection should never cause a color-colored urine.
Yeah.
Even there are rare reports of urinary tract infection, E. coli causing an hemolytic anemia presentation, but it will be not this much short history. There will be some week of urinary symptoms, and then the baby goes into an hemolytic episode. E. coli causing an hemolytic anemia, gram-negative bacteria, any UTI can cause an hemolysis, but it will be an extravascular hemolysis. There will be no any color-colored urine.
Okay, so I think, Dr. Madhav, is it right if I address you as a Dr. Swami?
Yes, sir. Please, sir. Absolutely, sir. No problem, sir.
Okay. Thank you. So now I think these are the points. Now, you can go further in your history part, please.
Yes. So in past history, there was no history of previous hospital admissions, no history of any prior similar illness, no history of previous blood transfusions, no history of noticing yellowish discoloration of the eyes or body before, no history of any previous urinary tract infections, no history of any abdominal surgeries. Antenatal history. Mother was a booked case, second gravida with one living child. Interval between two pregnancies were 5 years. Weight gain of around 8 to 9 kg till full term. And she has taken iron supplements from second trimester and continued throughout the pregnancy. Folic acid supplements were taken during the first trimester, and 4 to 5 antenatal follow-up were done. No history of fever with rash during pregnancy. There was no history of blood transfusions during pregnancy, no history of bleeding per vagina during pregnancy. Birth history, the child was born out of a normal vaginal delivery.
Yes, sir.
Sir?
I can interfere here, sir.
Yes, no problem.
So, someone in the group mentioned about hemoglobinopathy as a differential in this child. So, but when we go to the history of past, it was mentioned as there is no blood transfusion in the past.
Yes, sir.
But,
yeah.
But still, if you want to consider a differential diagnosis of hemoglobinopathy still in our mind, there was underlying hemoglobinopathy, and on the super added, there is still some event which is making to child to come to the hospital, acute precipitation and underlying chronic illness. So with hemoglobinopathy, you want to keep as a differential with no history of a previous blood transfusion.
Sickle cell traits, which...
Okay.
Or a sickle cell trait, which commonly...
Okay. Any other PGs? Sickle cell, I do agree. Trait. There will be no any history of transfusions in the past. They can be mild anemia. Any other differential?
So hereditary spherocytosis, so.
Okay.
Then.
Dr. Rahul, if I remind you, Dr. Swami asked hemoglobinopathy. So I think something is in his mind, right? So focus on the hemoglobinopathy. Hereditary spherocytosis is not hemoglobinopathy. It's a membrane problem, right?
Membrane.
Yes,
So
yes.
beta intermedia or beta thalassemia minor.
Absolutely. Intermediate is the word which should come here, which is an undergoing process of hemolysis, but the baby may not obviously present to the hospital. They will come to hospital when there is an other episode requiring a precipitation, maybe an infective episode or something like that. Thalassemia intermediate children may not require a transfusion till a certain age group, the spleen will try to do an extramedullary hematopoiesis and then it maintains. So I would wanted to bring the term thalassemia intermediate here because beautifully she mentioned that there is no history of transfusion. So we'll go ahead, sir. Thank you, sir.
Okay. Please go ahead.
Yes. So he was born out of a normal vaginal delivery, term gestation. Birth weight was 2.5 kg, cried soon after birth. There was no history of bleeding from the umbilical cord and there was no history of any birth injuries. Postnatal history, baby was noted to have adequate weight gain during the neonatal period. No history of bleeding from umbilical stem, no history of bleeding from any other sides. No history of any neonatal hyperbilirubinemia, no history of swelling of the skull soon after the birth. Developmental history, he was a developmentally normal child, gross motor wise. Now he can hop on one foot, climb downstairs with alternate feet. Fine motor wise, he can copy a cross. Social wise, he plays cooperatively in a group, goes to toilet alone. Language wise, he says songs, poems, tells stories. Immunization history. He's immunized as per national immunization schedule. Last immunized at 2 years of age and he was dewormed also 3 months back. Family history, there was no family history of similar illness, no family history of anemia, no history of jaundice or gallstones or blood transfusions in the family. There was no history of splenectomies done in the family. So diet history, he takes mixed diet and fiber-rich diet. Proteins and calorie intake were adequate for his age. Socioeconomic history, father is a graduate, he's a clerk, and mother is educated till 12th standard. She's a housewife. There are 4 family members, and per capita income comes around 18,000. He lives in a pakka house with no overcrowding. He belongs to upper middle socioeconomic class according to the modified Kuppuswamy's classification.
Okay, can you just stop sharing for a while? First, we'll clarify the history part. You have done the very well information. I think anybody, you have the question for Dr. Aijna, or if you want any clarification from her. Anyway, again, what I will draw attention of all the students from the exam point of view, that go for the relevant point. Sometimes suppose in a 10 years old child, if you start the developmental history from sitting, I think it's not right. Similarly, suppose here in this patient, of course, anemia is there, hemolysis if you are thinking, but I think history of bleeding from the umbilical stump or even the kidney hematoma, I think that may not be relevant to this point, right? Of course, if you are suppose discussing some coagulation disorder, that has a very strong relationship with the bleeding during the umbilical stump or something, right? So again, the point probably you should take in a proper perspective. Now, in the exam, they will always ask you the short summary from the history part. And don't repeat the same points which Alicia described. What we have understood from the history, that is very, very important point. Who will make the short summary? I want some voluntary participation of some student. Yes? Anybody? Dr. Sarojini, can you make it? Short summary that what we have understood from this our discussion, what is our hypothesis, what type of the problem we are thinking. Yes, Dr. Ankita? Come on, I think we should, whatever is even some small points, no problem. I hope that Dr. Viraj will do it. Dr. Viraj Desai.
Hello.
Yes, Dr. Sarojini, come on, please. Very nice.
This is a case of Anurag. He presented with fever and pallor of one day, and mother noticing cola-colored urine.
Right.
Hello. Hello.
Yes,
Am I
sir.
audible? Hello.
Yes, yes,
Yes,
come
please.
on, you are audible. Very,
Proceed.
very well.
Significantly, the child has not had any previous hospitalizations or any history of any past blood transfusions
Right,
or any significant past history antenatally as well.
right,
And dietary wise, also, the child has been receiving adequate diet in terms of calories, proteins, and micronutrients.
very good.
So far we have discussed that this could be something like a hemoglobinopathy, like a beta thal intermedia, which would not present acutely but would present later on with a precipitating event.
Okay, very good.
Yeah.
Anything else? Anything further? Anybody would like to add? Dr. Rajat?
In the summary, we need to mention that we discussed about hemolytic as also differential, sir. That Sarojini doctor did not mention, I guess.
Yeah.
Immune related hemolysis was also discussed. We need to mention that.
Okay, sir.
Yeah, thank you.
Anybody else would like to add something? Yes, Dr. Ankit has joined us. Good evening, Dr. Ankit.
Good evening, sir.
Yeah.
Sorry, I just joined a little late.
Dr. Ankit is a pediatric hematologist from Surat, already introduced to this gathering.
Yeah,
Anybody?
welcome, Dr. Ankit.
Yes, thank you.
I think simply if we can put the summary this way, please keep in mind. And one more point which I think wish to tell exam point of view or otherwise, never try to reveal the identity of the patient when you are talking. So best is not to mention the name of the person or the child. You can just say that 4.5 years old child, female, male, or XYZ. Suppose if you want to put it some other way. But don't try to reveal the identity of the patient. Even when you are talking, you can say that consulted by some pediatrician or hematologist. But again, we may not identify the consultant's name because it does not look nice when we are talking. Right. So that's the point. Always keep in mind. I think in this simple summary, we can put over here in this way that 4.5 years old male child is presented with very short history of only 1 day duration, and that is fever, very significant pallor which your mother has noticed, and the cola colored urine. And I think already from the rest of the history has been discussed. It is very obvious that the presence of fever indicates that at least there should be some inflammatory or infective condition. And that condition has led to development of significant pallor, that means severe anemia. And such anemia in the absence of loss of blood, which is not obvious in the form of either the trauma or portal hypertension, hematemesis or something, then probably hemolysis is more likely. And hemolysis also, if we think that it had developed within a very short time, so acute hemolysis is likely. Even in that case, presence of cola-colored urine indicates that intravascular hemolysis. And I think with that reference, if we try to, and at the same time, other history in the past, even there is no history of transfusion to this patient, not similar history in the family, and even rest of the points have been clarified. that probably this condition is not related in the probably some inherited problem. And then if we try to focus the only hemolytic anemia and which have developed acutely, then maybe even the ongoing hemoglobinopathy, like non-transfusion dependent thalassemia variety, or even sickle or something, which has been superimposed by this acute problem, or really in the form with the patients, acutely fever and other things we consider. It's an acute hemolytic condition, and then immune mechanism is more common. Then we can say some autoimmune hemolytic anemia. I think these are the points which you can just simply put forward, and that becomes easy for us to explain. Rather than don't go for the repetition of the same points in the history. Of course, already you have mentioned that in the antenatal, natal, and birth history, and even the past, there was nothing, any point which is notable, right? Is it right? I think, Dr. Ankit, should we go for further examination? Dr. Swami?
I would like to highlight one point that
Yes,
in
sir.
absence of
Please.
any drug history,
Yes. Very important point.
Because G6PD can come with and patient has got fever and might have taken some NSAIDs which can precipitate hemolytic anemia. So drug history would be very important in part of history.
I think, Anjana, what we were discussing negative points, here on the strong point, what Dr. Ankit mentioned, we should positively mention that there is no history of any very specific drug like non-steroidal anti-inflammatory or even the sulfa-containing medicine. You may make it even clear.
Yes.
That is a very strong point to make it. I agree with you. Yes, very important. Okay, Anjana, you can go ahead with the examination.
Okay. So on general physical examination, child was conscious or active alert. He was examined while lying down supine on the bed and in sitting position. Child appears comfortable and playful. Vitals, temperature was 98.6 degree Fahrenheit while examining. Pulse rate was 140 per minute, regular rhythm, good volume, no radial or radiofemoral delay, and all peripheral pulses were well felt. Respiratory rate were 44 cycles per minute with minimum intercostal retractions. Blood pressures were 98 by 60 millimeters of mercury. Saturations were 98% on room air. Anthropometry.
I think, Dr. Indira, just can you stop sharing? Because if you go further, we may just forget or miss the focus. I want the interpretation of the vitals from one student. What she had mentioned, the vitals, how will you interpret it? What does it signify? She said that the temperature is 98.6, pulse is 140, respiration rate 40. I think blood pressure is okay, saturation is okay. But how will you interpret it with this already description of our case? How will you explain? Or what does these vitals indicate? Number one, always ask the question, is it normal or abnormal? Yes, come on. Dr. Viraj or somebody, is it normal or abnormal?
Hello, sir. Hello. Hello. Hello.
Yes, Viraj, you're audible.
Yes. As the temperature is 114, the suggestive tech and RR is also 44 breaths per minute. That is also on higher side. Suggestive tachypnea and tachycardia. As we have seen pallor as we have noticed pallor in the patient, that as in the histories come with the noticing pallor. This could be one size of anemia with CCF.
Absolutely. Anybody else? Dr. Indira, what is your explanation? For tachycardia and tachypnea, I think very rightly Dr. Viraj mentioned.
Yes, sir. So,
and I think fever is not there. Its child is not febrile.
Yes, sir. So one thing, as Viraj mentioned, it can be like anemia, which causing a tachycardia to compensate for the body needs. And other possibility can be if that fever is related, like in the history anyway, it's not there any respiratory symptom.
What is my another point? You must have seen certain patients, children, even entering your ward with a 3 gram hemoglobin sometimes, but they are walking. Not,
Yes.
I will say, bad, comfortable. And here, probably child is quite tachycardia. So from this point of view, I want to know what will be your interpretation. Both the patients are having hemoglobin, almost maybe the similar hemoglobin.
Yes,
but
sir.
one child is tachycardia. Another child is even less than that hemoglobin, but comfortable, walking your ward. So what is your interpretation?
So if it's a chronic anemia, then the child will be stable, sir, with the...
Absolutely. Very good. Very good. You know, this is the point which I wanted, that we should interpret that this is an acute anemia. And child has not got the time for compensation. So there is no compensatory signs. It has presented acutely. Even such patient can go for cardiac failure also. And another child with a 3 gram may be comfortable, may not be cardiac failure. Because you know that chronic anemia, body is getting the time for the adaptation with the developing situation. Here, you know, sudden loss, road accident and sudden loss of blood and anemia, the child will go for tachycardia, tachypnea, cardiac failure, anything, everything. So that was the only point which I wanted, the interpretation of vitals here, that patient is having the acute sudden developing anemia, right? That's the point. Anyway, go ahead.
Another thing that...
Yes, sir. Dr. Ankit, please.
Yes, that patient is not having severe anemia, very severe anemia, which is causing hypoxia and irritability in child. So patient might have moderate anemia if you see investigation wise, because in hypoxic child, patient is usually irritable, particularly if patient has lost so much amount of blood. So that we also can think that this could be around HB, maybe around 5 to 7, and patient might not have the hypoxia yet.
I agree with Dr. Ankit. They're absolutely right. I think here it's made a very good comment that not only acute or chronic, but even degree of the anemia also you can predict. Absolutely. Suppose severe, we know that acutely developed, patient will go for hypoxemia or something, then manifestations will be there, child will be irritable, or even something, even circulation may not be maintaining. So I think very good point. Both the things, acute and chronic, as well as severity, you can predict from the vitals. Thank you very much, Dr. Ankit. Yes, Anjana, you can go further.
Yes. Anthropometry wise, his weight was 15 kg. So weight for age comes to 0 to -2 standard deviation. Height was 101 centimeters. Height for age was 0 to -2 standard deviation. Head circumference was 51 centimeter, which comes to 0 to +1 standard deviation. Mid upper arm circumference was 15 centimeters, and weight for height was 0 to -1 standard deviation. Head to toe examination. Head was normal size. Body hair appears light brown in color. Eyes normal, no signs of vitamin A deficiency. Ear was normal. Frontal bossing was present. Depressed nasal bridge. Hemolytic facies present. Pallor present. Icterus present over the bulbar conjunctiva. Tongue, smooth tongue with atrophied papillae. Lips and oral mucosa appears pale. No glossitis, cheilitis, or angulostomatitis. No significant lymphadenopathy noted. No cyanosis. Nails appears flat. There was hypopigmented macular patches over the cheek, bilateral upper limbs, and lower limbs. Chest, there was no deformity. Abdomen, no dilated veins, scars, sinuses. Extremities, no limb anomalies, no cyanosis. Pallor was present over the palms and soles, but no edema. Skin, no petechiae, purpurae rash. Genitals were normal, and spine also normal. So shall I go to the systemic examination?
Yes, sir. Please complete.
So per abdominal examination, inspection, abdomen appears normal in shape. All quadrants move with respiration. Umbilicus appears central, no visible mass dilated veins. No scar, sinuses, visible peristalsis, and hernial orifices were intact. On superficial palpation, abdomen was soft, no tenderness, no guarding or rigidity. On deep palpation, liver was palpable in the right hypochondrium, 2 cm below the right costal margin in the mid-clavicular line, which was firm in consistency and smooth with rounded margins. There was no palpable spleen, kidneys were non-ballotable. Percussion, tympanic note heard all over the abdomen, except areas of liver dullness. Liver span was 7 centimeters. On auscultation, bowel sounds heard were normal. Other systemic examination, CVS examination, S1, S2 was heard, no murmur. RS examination, breath sounds were bilaterally equal in intensity, no normal vesicular breath sounds, and no adventitious sounds heard. CNS, he was active alert, tone was normal, power was 5/5 in all group of muscles, reflexes were present, no sensory impairment, and no cerebellar signs noted.
Okay, can you just stop sharing?
Yes.
Okay, now, so what are the points, positive findings on examination? Who will take the first student? The positive points on examination. Yes, Dr. Viraj, can you take it? What we are already vitals we have interpreted? Beyond vitals? Dr. Ankita or anybody? Rahul? Dr. Rahul, are you there? I think just being silent and listening does not add much. Please come on and participate, answer. Yes, Dr. Rahul, come on.
Yes, sir. So basically now on examination, we are thinking like it looks like because it is non-transfusion dependent. And
no, we'll never jump for the diagnosis. Just try to locate what are the positive findings on examination. What we got the positive findings. Then try to think that with the reference to these findings and history, what are our possibilities? Then we'll keep some conditions. But first, what are the positive findings? Already she described.
First, sir, in general examination, there was tachycardia with tachypnea, which basically goes directs towards same anemia with CCF, mostly. Then
please keep in mind, there are no other signs of CCF. We can't say CCF. There is no edema. She made the point clear, right? There is no enlarged liver. There is no tender liver, right? No chest signs.
No gallop rhythm.
So signs of cardiac failures are not there. Of course, tachycardia and tachypnea are there, right? That indicates, it can be, that means it is a compensatory phase of the heart. Heart has not gone for the decompensation, right? That should be our interpretation. Okay, anything else further?
Is there?
If I ask the direct question, I think she mentioned hemolytic phase, Dr. Anjana.
Yes, sir.
Suppose hemolytic phase she had mentioned, what is your explanation? What does it indicate? If you are discussing the acute condition in a one day, I think it will not cause the hemolytic phase. So suppose if we consider our findings and we don't have the patient over here, unfortunately she has not brought some photographs. I request other students in the future that you may take some photographs so that we can show all the friends and it will be convincing to us. But suppose we believe that she is right, then how will you explain the hemolytic phase? Or what does it indicate?
What are the differential diagnoses for hemolytic phases?
Yeah. But
So
sorry, it's a
hemolytic,
big idea.
so mainly extravascular hemolysis
Okay, like?
and chronic hemolytic anemia.
Yeah, so keep in mind that we are discussing acute hemolysis, but there may be chronic hemolytic condition. At least chronic, some condition, chronic anemia, keep it like that. Not necessarily always even hemolytic. Chronic, even iron deficiency anemia of long standing can also give rise to some changes. So not necessarily always hemolytic, but at least indicates some chronic anemia. And in the presence of, suppose if you say hemolytic phase, then more likely hemolytic condition. Chronic hemolytic condition, at least you can keep in mind, right? Or maybe some nutritional chronic condition. I think that's a comment which you can make it. Okay. What are the other findings? I hope that when she's discussing, we'll have to note everything. She has said number 1, severe pallor. She has mentioned the jaundice. Icterus, she has mentioned that present. What was my question? If you have heard properly, or let me ask directly to Dr. Anjana, what is your interpretation regarding the liver?
So there is a 7 centimeter liver span is around 7 centimeter, but there is
span
no
7
10.
centimeters. Suppose normal or abnormal for 4.5 years old child?
It is normal, sir. For it.
Yeah, it's normal. So size is normal.
Yes, sir.
But
There is no tenderness.
Interpretation, liver is normal or abnormal?
No. Sir?
What is your interpretation? Size is normal.
Yes, sir.
But as a whole, findings of liver are normal or abnormal? How you are taking? What you in whatever we are taking, you can tell, no problem.
Yes, sir. It appears to be normal to me.
Okay, but you said consistency is firm?
Firm consistency, yes.
And firm consistency is normal?
No, sir.
Yeah, so these are the points. Size may be normal, but if you consider the firm, then probably again it indicates some chronic condition related to liver. Of course, the size is not hepatomegaly. Right, these are the things. Splenomegaly is not there. Second, very specific, you should mention no lymphadenopathy in this patient. Because that is very important, presence or absence of lymphadenopathy. Positively, you should mention. Now, suppose in this patient, if I put the picture of finding, the child is alert, playful, what she mentioned even. Right? Vitals point of view, tachycardia, tachypnea, significant pallor, icterus is present, no edema, liver is normal size but firm in consistency, no palpable spleen, no lymphadenopathy, and probably no any specific skin changes. But of course, hemolytic anemia as we mentioned. Is there another positive finding, Dr. Anjana? I don't think so. And if I missed, please. Now, having this clinical picture, what will be your thought process? What actually I want to convey to you, what I want to sensitize, that always try to derive the positive findings. Put on the paper. Give the thought that what does it indicate? Then give the further thoughts that in which type of the pathology this type of the picture is possible. Give the further thoughts that which conditions can present in this way. And then put some possibility 4 or 5, common first, then less common, and rare last. I'm sure if you think in this way, it will be more feasible. I think first any student, if they contribute, otherwise we'll go to the experts. That, first Rahul, what will be your interpretation from these findings?
Jaundice is interpretation, sir.
What does it, jaundice, what does it indicate? What you are expecting jaundice with a direct type or indirect type in this patient?
In this patient, because of hemolysis, indirect type.
Okay, you are expecting indirect, right? Okay, you can take it further. Hello. I think to save the time, I request Dr. Badeva, can you take it, please? Dr. Anki? Yes, Dr. Swami, can you take it?
So there is pallor, there is icterus, short history. First of all, the history is very short. And short presentation with a sort of febrile episode. And in the clinical examination, we have a pallor icterus. So we kept a hemolytic was one differential in your mind. And this, I can't call it hepatomegaly, but there is something related to liver dysfunction happening. So
there is a anemia which is moderate to severe in grade. Maybe we can consider severe if there's a Palmer pallor. Okay. So severe anemia, acute in origin, in possibility of acute febrile illness with jaundice, without hepatosplenomegaly, most probably due to hemolytic anemias, possibility due to autoimmune in origin, without any growth failure, without any hemolytic anemia, chronic hemolytic anemia changes. So we are dealing with mostly autoimmune hemolytic anemia. That could be the first differential. Second could be acute liver failure, though it's not very classic, but it can come like that. Cola colored urine, when there is a very high level of jaundice, that can come with this cola color type of urine, dark color urine. Okay. In which there can be a fever, there can be anemia, there can be a jaundice, and there can be a cola colored urine without signs of hepatosplenomegaly. That could be one possibility. I'll put second differential as a acute liver failure also. Maybe infective origin or autoimmune in origin.
Okay. So I think these are the things that how we can consider. Anjana, in your
point to add from my side is I'm not able to accept the examination of hemolytic facies here. The moment we say hemolytic facies, the typical chipmunk description she has given, that typically we see in hemoglobinopathies. But somehow, since the history is short and there's no transfusions history, somehow not able to fit that finding into the given scenario and without splenomegaly. So I'm not able to take out that from my mind, how to fit the hemolytic phases into given scenario. I would like to have a comment from Dr. Ankit, how to fit into hemolytic phases in this case.
So hemolytic phases doesn't mean that it rule out a hemolytic anemia. So hemolytic anemia can be acute or can be chronic. So when there is a chronic hemolytic anemia, like we see in thalassemias, maybe sickle or other hemoglobinopathies, which are mostly a transfusion dependent anemia, where extramedullary hematopoiesis are happening for a long time. Even on thalassemia, even in sickle, see, if you see a sickle patient, you don't see a very typical of chipmunk phases. Okay, so absence of this facil doesn't rule out hemolytic anemias. Okay, it may be the first episode of G6PD induced G6PD deficiency hemolytic anemia. So G6PD patients are not always a transfusion dependent anemia, but there are some cases where G6PD patient can have a recurrent episode of anemia, hemolytic anemia episodes, and they can have phases like chipmunk phases. So it is very not absolute for a hemolytic anemia. It is mainly for the chronic hemolytic anemia, mostly transfusion dependent.
And how to fit a warm antibody hemolytic anemia here? The points against from my side is one, the presence of a cola-colored urine, and second one, absence of a hepatosplenomegaly. Any PGs to comment how to defend that there is no hepatosplenomegaly and still you keep a warm antibody hemolytic anemia?
So thinking of the acute onset of the disease, like autoimmune causes are being kept. And in the autoimmune hemolytic anemias, like between warm and cold, warm type of autoimmune hemolytic anemia will be more severe type, which will cause severe pallor than the cold type. So
I think antibody has nothing to do with hepatosplenomegaly or like that. Okay. So even warm or cold antibody, or there are some other type of AIHA where there is no hepatosplenomegaly. So antibody has nothing to do with hepatosplenomegaly. Hepatosplenomegaly is a response to your hemolytic anemia. If they are happening frequently, so your bone marrow is not able to compensate your hemolytic anemia. That's why extramedullary hematopoiesis is happening. So liver and spleen are also site for extramedullary hematopoiesis. So in autoimmune, particularly in first episode, there is no time for your body to react to develop such a hepatosplenomegaly. But in some cases, you may find splenomegaly also. Okay, so it's not absolute, and it has nothing to do with warm or cold antibody.
Now, I just brought that so that PGs will think that the hepatosplenomegaly may not be a compulsory for an hemolysis. Just I brought the discussion.
Yes.
And how to fit the cola-colored urine here in this case?
Yes. Ankit, what is your idea?
Yeah. So cola-colored urine means there is either hemoglobin, either RBCs, or there could be a high level of bilirubin. So these are the three possibilities which can cause dark colored urine, and there are very rare cases of poisoning also. So when there is a hemolysis is happening, so your RBCs are being broken down, either maybe because of antibody or macrophage activity, whatever is the cause, and they will be converted into unconjugated bilirubin. Okay, so indirect hyperbilirubinemia, and we have some capacity that we can convert that into bilirubin. If their capacity of liver is gone up, so they will start removing this extra bilirubin into the urine. So that will give us a dark colored urine particularly. So, but it is not very absolute for only indirect hyperbilirubinemia only. Hemoglobinuria is very typical for dark color, that is cola colored urine. So if your hemoglobin is in the urine, it typically gives, mother will give the history of dark color, that is cola colored urine. Okay, hematuria is different. Cola colored urine is different, because hematuria you may see a reddish particularly tinge of urine, while this will, if you compare with the cola Pepsi or whatever it is, you will see that there is no difference between these two. So this is a hemoglobinuria is happening. Okay,
agree. Hemoglobinuria will fit into cola colored urine, but maybe in this case I feel the dark color urine by the mother would have that whatever high bilirubin which is there in the blood, in the urine, would have made the mother to confuse with the cola colored urine. So I mean, there is one differential I would like to keep here. Sometimes we hear a story, gets up in the morning, the child passes a cola colored urine, as the day passes up the color becomes all right. So any differential by the species for this complaint with a anemia, severe anemia, hemolytic like feature, cola colored urine in the morning, and then becomes better? Any differential thought process?
Paroxysmal
hemoglobinuria.
Yeah, absolutely.
PNH is so rare that I have not seen any patient of PNH.
Agree.
So it's very rare.
Absolutely.
Yeah, and may not be a first episode in this 4-year old child. Also very, very, very rare. We have not seen a 4-year-old child coming with a PNH.
I think, is there a possibility of any systemic disorder which can present this acutely with the hemolytic anemia, like SLE or Wilson, or even sometimes some infections like even hepatitis A, like benign disease also?
So acute liver failure, any viral infection induced acute liver failure can come like this. And
Right.
our children are mostly, they have at least mild degree of anemia. Any decompensated like infection which cause the bone marrow suppression for temporary, they might end up into moderate or severe anemia. And jaundice could be part of liver failure. And as I already suggested, there could be direct or indirect hyperbilirubinemia, which can give rise to a very dark color urine. So viral hepatitis could be a possibility in differential. We have to keep in mind.
Anyway, I think one point which Anjana I would like to say, and to all the students, in your presentation, growth chart is missing. And I will say any pediatric presentation, growth chart should be there. Whatever the case, even the CNS case, malnutrition, hematological, respiratory case. Anyway, I think you can go for the investigations, and I request the expert to focus on the investigations. One of you can take one by one for the interpretation so that probably we can learn. And today, due to some reason, we'll have to end at 7:30. So we have probably 50 minutes or so.
So investigations wise, hemoglobin was 2.7 milligram per deciliter. Total counts were 21,100.
Sorry, Anjana, to interrupt you, but please correct it. 2.7 gram per deciliter.
Yeah, yes. Sorry.
Maybe mistake, but please keep
it. Yes. Neutrophils were 55%, lymphocytes were 30%, monocytes were 6%, eosinophils were 2%. Platelets were 2.5 lakhs per milliliter. Reticulocyte count was 1.1%. Liver function test, total bilirubin was 2.7 milligram per deciliter. Direct bilirubin was 0.75 milligram per deciliter. SGOT was 62 international units per ml. SGPT was 25 international units per ml. LDH was 1,253 units per liter. MCV was 72. MCH was 21. MCHC was 29. Peripheral smear was showing a mild hypochromia, mild anisocytosis, microcytes were seen, and platelets were adequate.
So I would want to ask one question to PGs. What is the one of the surest sign or surest investigation in or you can say marker in CBC which can give us that this is autoimmune hemolytic anemia from CBC, which is the one of the marker. Okay, by CBC, if this is a high, then we can certainly say that this is autoimmune hemolytic anemia. Anyone?
Reticulocyte count.
No, I am talking about CBC. In CBC, which is the parameter which can gives us a hint that this is autoimmune hemolytic anemia, particularly warm antibody induced. Anyone?
So with hemograms, sir, you're saying?
No. I am only talking about CBC, no other investigation. In CBC, there are different parameters like HB is there, hematocrit is there, MCV is there, WBC is there, platelet. So which is the parameter that can give you the hint that this is assuredly this is autoimmune hemolytic anemia?
So MCHC?
No. It's MCV. So when you have a MC which is disproportionately high, like if this patient has a MCV of 120, 130, which is very disproportionately high, it is a surest sign of autoimmune hemolytic anemia. Because what happened? So RBC tag antigen and antibody, they will try to stick with each other and they will develop one big cell, which will give rise to a very high MCV, which is one of the very, we can say a positive signs in CBC that can tell by this is autoimmune hemolytic anemia. So very high MCV is very important when you interpret the CBC. Okay. So why the WBC counts are very high in this patient?
Maybe there's an ongoing infection. There was a history of fever since one day.
Anjana, you have any presentation further?
No, sir. Done, sir. This is the
I
last
think just
slide.
you can stop and we can come to this. I would say stop sharing so that we can have the good discussion. Anyway, I think Dr. Ankit has asked a very good question. Why this WBC increase?
I'll say
In
this is
short,
not
if
because
I
of
give the
infection.
hint, it is really leukocytosis or due to some technical reason it has increased. Yes, Dr. Ankita, she appeared, but then she disappeared. Yes, you can. What is the reason for the, suppose Dr. Ankit gives another hint that it is in the true sense no leukocytosis. Then what it could be?
If this patient comes with 1 lakh count.
Yeah.
Because of increased bone marrow
Yes.
cell turnover.
No. Yes, you are partially right. Okay. So the reason is nucleated RBC will start coming into the blood, peripheral blood, and your cell will start counting as a leukocytes. Okay. So there is a pseudo leukocytosis. So nucleated RBC usually comes when there is a rapid hemolysis going. So what bone marrow will try to compensate with that anemia, producing more and more red blood cells, and in this type of hemolytic anemia, and there are so many nucleated RBC which are counted as a WBC. That's why the WC count can high. It could be in 10 lakhs, 8 lakhs also.
Yeah. I will simply explain the student that why it happens so. Which the problem we were not facing in the past when we were student, because there were no the cell counter. Right. Now what happens? Then in the machine we have fed that these type of the size of the cell with the nucleus should be considered WBC. Machine is not able to differentiate that this is the progenitor cell of the RBC series. So, and you know what happens as already Dr. Ankit said in hemolysis, overwhelming bone marrow response will send the premature cells in the circulation. You know, so the normoblast. Now, the normoblast are the nucleated cells, larger in size. Therefore, these our cell counter will not be able to differentiate. All these normoblasts will be considered as the leukocytes. And therefore, it gives this leukocytosis of the high count. But suppose the pathologist or the hematologist is even doing himself, then he'll be able to give the corrected count. That this is not the high count. Because he can differentiate that this is the normoblast and this is the leukocytes. So I think this is a technical problem which should be taken properly. Sometimes people are thinking for leukemia or something, yes. And that is very common mistake if you are not having this point in mind. So not even in this type of the case, but several other places. So please keep in mind that this is a technical issue that we should keep in mind. Yes, Dr. Ankit, thank you very much. I think very good point.
So now HB is 2.5 or 2.7. So what is the degree of anemia in this patient from CBC? Students?
Severe anemia.
Anyone else?
Severe, or would you like to add one more adjective to severe? What is regarding the grading of anemia at present? What are the, I will say, gradings are given? Mild, moderate, severe, anything beyond that? Tanjana?
I don't know, sir.
Is there any very severe?
Yes, very severe.
Very severe.
Right, it comes in a very severe. Even somebody is going to ask in the exam, so you should know different levels. The 10, right? 10 to 7, 7 to 5, less than 5. So like that, we have to keep in mind.
WHO grading for anemia
obviously comes in very severe.
Yeah. So now the another point is retic. This patient's retic is not high. So can we rule out hemolytic anemia if retic is not high? Can normal retic rules out hemolytic anemia?
No, sir. Actually, if the even the history is so acute, so if the first retic count is, even if the first retic count is normal, we cannot rule out hemolytic cause.
I think before that, Angela, what you should do, you should go for correct calculation of corrected retic count. Right? That will give the real idea that how much retic count you should consider. Yes, Dr. Ankit, please take it further.
Yeah. So now the bilirubin is around 2.5 or something, and indirect component is very little bit high. Okay. But if you see the patient's HB is 2.7, but bilirubin is not that much high. If you see कि patient का hemolysis तो बहुत होना चाहिए कि patient का HB 2.5 है. So does it tell us that we are having another differential diagnosis or liver disease can be there? If yes, then give explanation. If not, then give explanation. If you look at this LFT, can it be this liver failure in this patient?
The transaminase levels are also not that raised, sir. So,
another point. So one is SGOT, LGBT is not elevated. Another is there is no direct hyperbilirubinemia. Whenever there is a liver abnormality, particularly parenchyma is involved, will be a direct hyperbilirubinemia also. Okay, so direct, indirect, both will be there. Most of time it's a direct which can we see in our routine investigation if there is a liver failure or liver is involved, and of course parenchyma is involved, then SGOT, LGBT will be very high. So apart from this, why the LDH is very high in this patient?
Just Dr. Ankit and Dr. Swami, sorry for interruption. I conveyed to Dr. Vaishali that due to some reason I have to take the leave. So please consider me and please continue the discussion.
Yes,
A very good discussion is going on. Please continue. I'm really
Yes.
extremely sorry, but I have
No
to
issues.
take it.
Thank you very much, sir. It's nice to meet you.
Thank you, sir. Thank you.
Thank you very much.
Thank you.
Yes. So why LDH is high in this patient?
Sir, LDH is an enzyme which is present in the almost all cells in the body, but especially RBC. So if there is an ongoing hemolysis, then the LDH levels will rise.
No. So LDH is a marker of increased cell turnover. Okay, when there is a cell turnover is high, whether it's happening hemolytic anemia. So what are the other conditions which can give rise to high LDH?
Any inflammatory conditions?
No. You have to give the proper disease name.
High cell turnover. Cells are increasing.
Leukemia.
Cells are dying and regenerating. Okay, which are the conditions in which this is happening?
So leukemia.
Yes. Okay. Another then?
Complicated malaria also we can have a high LDH.
So we can say there is a one hemolytic anemia. Malaria is infection-induced hemolytic anemia. Okay. So hemolytic anemia. So leukemia, lymphoma, like hematolymphoma malignancy, which is another one, very common one. We see in pediatric population a lot. Megaloblastic anemia. So in megaloblastic anemia, there is a cell arrest. So what bone marrow will try to do? It will try to produce more and more. That's why we have a macrocytic anemia. Okay. So in that LDH is usually very high. Okay. So LDH is a marker of high cell turnover. So it helps us to see there is increased cell turnover is happening. Maybe it is because of hemolytic anemia, could be because of malignancy or because of megaloblastic anemia. So now, apart from all these, to diagnose this patient, what are the investigation you will prescribe? So you have prescribed CBC, peripheral smear examination, retic count, and LFT. Okay, and LDH and so in this patient, ferritin is very high, more than 3,000. Will you give steroid in this patient without doing another investigation?
No, sir.
Why? Why there is a high ferritin in this patient, 3,000? So ferritin is also acute phase reactant. Okay, so any infection or inflammation, ferritin could be high. So that's why whenever we are checking a ferritin level, in particular iron deficiency anemia, we'll tell के patient का acute infection period खत्म हो जाने दो, and then we'll do the investigation. Otherwise, it can be falsely high. So ferritin is acute phase reactant like CRP. So any infection, inflammatory condition, it can be very high. Okay. So HLH, it is another disease where our ferritin is very high. Okay, so now what are the other investigation you will look for in this patient?
Hemoglobin electrophoresis for to rule out any
Are you
hemoglobin.
suspecting thalassemia or sickle cell or any hemoglobinopathy in this patient? अरे HB electrophoresis का रिपोर्ट आने में कितना टाइम लगता है? Now this is patient is HB is 2.7. If you don't act immediately, patient may die. HB electrophoresis का रिपोर्ट प्राइवेट में 1 दिन लगता है, सिविल में 1 हफ्ता लगता है. So will you wait for the report?
Sir, can we send serum?
Pardon?
Someone said serum haptoglobin, if I'm not wrong.
I have not prescribed in my life.
Someone mentioned.
These hi-fi investigations are not for us. Okay, what are the investigation? What are your first primary suspect etiology in this patient?
Autoimmune process of
So what are the investigation you will immediately try to find out?
DCT, direct Coombs test.
Yes,
which
direct Coombs test and indirect Coombs test both.
both.
Okay, that will give you immediate diagnosis if patient is having DCT +4. अभी ऐसा बोल रहा है कि भाई DCT ICT लैब वाला बोल रहा है कि आज नहीं हो पाएगा. Okay, so what are the other investigation or what we'll try to do in this patient? What is the next response in this patient? You are sitting in your private hospital at 10 o'clock. This patient has come with this. Okay, investigation करके आया इतना. What is your prompt response? 2.7 HB patient is in CCF. Okay. What is your prompt response in this patient? What is the first line of treatment you will give this patient?
First of all, we have to hemodynamically stabilize the patient, sir.
Okay, how you will do that?
So if there is a like as in if there is a shock component of there is an hypoxia, oxygen can
This
be
is the
provided.
patient you have already mentioned the vitals. Okay, there is no hypoxia, there is no shock. Okay, patient just have a tachycardia, tachypnea, and HB is 2.7. Okay. पेशेंट को सबसे पहले ट्रीटमेंट क्या दोगे? एनीमिया में ट्रीटमेंट क्या करते हो इन दिस पेशेंट?
ट्रांसफ्यूजन.
ओके, सो यू विल सेंड पेशेंट के भाई ब्लड लेके आओ. रिलेटिव बोल रहा है कि ये पेशेंट का ब्लड कहीं पे मिल नहीं रहा है. इट्स नॉट एबल टू, वी आर नॉट एबल टू टाइपिफाई द ब्लड. व्हाट इट इंडिकेट्स?
So indirectly relative बोल रहा कि कुछ टेस्ट कर दिया हमने.
हाँ, okay. So parents are giving you a diagnosis that this patient is DCT ICT is positive. There is no typeable blood is available for this patient. Your diagnosis is there. Autoimmune hemolytic anemia. It's labeled. You don't need to wait for any investigation. Okay. चलो ब्लड नहीं मिल रहा, अभी क्या करेंगे? तुम्हारा डायग्नोसिस हो गया, ऑटोइम्यून हेमोलाइटिक एनीमिया हो गया. Now what is your next line of treatment? ब्लड नहीं मिल रहा है, अहमदाबाद की पूरी 25 ब्लड बैंक से नहीं मिल रहा है, और पेशेंट इन्वेस्टिगेशन के लिए क्या दोगे स्टीरॉइड में?
प्रेडनिसोलोन.
क्या डोज में कैसे दोगे?
So prednisolone can be given at a dose of 1 mg per kg per.
ओरल देंगे ये पेशेंट को? 2 दिन के बाद डीसी भरना पड़ेगा फिर उसका, अगर ओरल दिया तो. Patient is in CCF, HB of 2.7. You are not getting blood. You have to give injectable. There is no chance of giving oral. So first line of treatment is IVIG. Okay. Okay. So IVIG is not available. Then you have to give MPS. That methylprednisolone you have to give. Okay. So what is the mechanism of MPS or steroid in this autoimmune hemolytic anemia? वो क्या करता है? How it's helping in autoimmune hemolytic anemia? Mechanism of action of steroid.
Dr. Ankit, I can interfere if you don't mind.
Immune process is.
Yes, क्या करता है वो? So what is autoimmune hemolytic anemia? क्या पैथोफिजियोलॉजी क्या होती है इसमें?
Auto antibodies against the RBCs.
फिर क्या होता है? आरबीसी एंटीजन और एंटीबॉडी अटैच हो गए, फिर क्या होता है?
Complement reaction. Complement system is being activated.
कौन खा जाता है ये सब? आरबीसी को कौन खा जाता है? मैक्रोफेज खा जाते हैं। जो आरबीसी टैग जो रहता है ना, एंटीजन एंटीबॉडी, वो मैक्रोफेज खा जाता है। पेशेंट का मोनोसाइट्स काउंट देखो कितना है, हाई है, 6%. Okay. That also indirectly tell that there is a macrophage activity is going on. That's why your ferritin is high. Okay. So it's like HLH only. Okay. So antigen antibody जो भी आरबीसी के साथ होता है तो वो मैक्रोफेज खा जाता है, ठीक है। तो स्टीरॉइड क्या करेगा? एक तो मैक्रोफेज एक्टिविटी को कम करेगा, इवन एंटीबॉडी प्रोडक्शन ऑल्सो विल बी रिड्यूस, बट इट टेक टाइम। ओके, बी लिम्फोसाइट को मैकेनिज्म से एंटीबॉडी प्रोडक्शन कम करवाएगा स्टीरॉइड, बट इट विल टेक टाइम। So immediately you have to give IVIG, that is 1 gram or 2 gram per kg. Immediately you have to give, considering your renal function is normal. So you have to do renal function test first. Creatinine of the patient should be normal. Okay. So IVIG you have to give. Okay. Blood नहीं मिल रहा है. Then after 1 dose of IVIG, till you have to stabilize the patient. After 24 or 40 hours, you have to resend your blood demand. Okay. You can give IVIG plus methylprednisolone, particularly in this patient when there is antibody titers are very high, where you are not getting a typeable blood. So methylprednisolone, IVIG plus or minus, or you can give both also. Okay, and the facility of IVIG or patient is not affording, then MPS, methylprednisolone, you have to start immediately. Okay. Apart from that, you have to give folic acid also. बराबर, पेशेंट का ब्लड बनने के लिए रॉ मटेरियल चाहिए, hemolysis is going on, so you have to support with folic acid. Okay, you have to make sure that patient doesn't go into renal failure, because all this hemoglobinuria and can give rise to acute renal failure also. So you might have to check for renal function very frequently. You शायद उसको थोड़ा बाइकार्ब डाल के ये भी करना पड़े. Okay, depends how the patient is clinically. Patient is not going into renal shutdown or so. First is blood. Second is your immunosuppression. Third is supportive therapy. That is the treatment of AIH. And AIH is very important emergency. If you have known the patient how to manage, it will respond within 24 to 48 hours or maybe 72 hours. Okay. If you miss the patient might die just because there is no blood available. Okay. Yes. So anything you want to add, Dr. Madhav? Resident, if you want to ask any question, you can ask.
Questions to postgraduate from my side. How to fit a microcytic RBC in this picture? And how to fit the low reticulocyte count here, though we have kept a differential diagnosis of autoimmune hemolytic anemia. The PG is presented as MCV 72, if I'm not wrong.
Yes.
And in the peripheral smear, there was no polychromasia, there was no NRBC mentioned.
What are the signs of hemolytic anemia in peripheral smear?
There are damaged RBCs like the helmet cells.
Helmet cells आज को कोई पैथोलॉजिस्ट नहीं देगा. I have not seen a single pathologist giving a description of helmet cells in nowadays practice.
It will be normocytic pneumochromic hemolytic. This will be normocytic pneumochromic.
Microcytic भी हो सकता है. Patient iron deficiency anemia हुआ तो.
Underlying iron deficiency.
थैलेसेमिया minor हुआ तो. We don't know.
Absolutely.
Okay, so it could be normocytic, normochromic, macrocytic. It can be microcytic. It is not a it's not a fix that patient will come with the normocytic only. Okay, our patients 70% are iron deficient. They are already microcytic. Okay, so MCV is not that reliable unless it's very high. Okay, and why not? Retic is not very high in this patient. 10%, 15% नहीं है इसमें.
Because it's an acute
Anyone else? अरे hemolytic anemia mostly acute condition में ही आते हैं जब first time अपने आते हैं, whether it's a thalassemia, whether it's a sickle cell, whether it's a G6P deficiency, whether it's autoimmune hemolytic. So when they first come to us, they are usually come in acute condition only, most of the patient. Okay. So infection bone marrow suppression करता है क्या?
Yes.
So there could be 2 or 3 mechanisms which can give rise to. Sometimes what happens that one bone marrow is not having a sufficient time to react also. So that could be a rating is not high. Another is faulty technique particularly. Okay, and you always have to do the correct retic count. It's online available. Google, if you Google it, you will get the corrected retic calculator. You can always find out corrected retic count by putting some data in your that application, or in infection also can cause the low retic. Okay, so what is retic count? Retic count is your response to anemia. Okay, so your body is trying to compensate with the degree of anemia. Okay, so what will it will try to produce more and more RBCs. Okay, so जितना RBC प्रोड्यूस होगा तो बोन मेरो में कम जगह है, तो बोन मेरो क्या करेगा कि भाई बाहर फेंकेगा, तो रेटिक फेंकेगा. करेक्टेड रेटिक बोलेगा अपने को कि भाई करेक्टेड रेटिक इज न्यूली डेवलप रेटिक, नॉट ओल्ड प्लस न्यू. So corrected retics give us exact idea that your bone marrow is responding to degree of anemia or not. जैसे hereditary spherocytosis का हम लोग retic count देखेंगे तो it's very high. Some in 20%, 30%. Okay, thalassemia में देखेंगे तो 3%, 4%. Even if it's in a hemolytic anemia, because there is what is happening in thalassemia. Okay, it is ineffective erythropoiesis is happening. So there are not sufficient RBC or the progenitor cells in RBC series, okay, which are going into the retic phase also. So they don't have that much of reticulocytosis. There's a sickle mein, there is very high reticulocytosis. So this way you can differentiate whether the patient is having sickle cell or thalassemia. Okay. And what will happen that once patient starts stabilizing, you might see there will be a jump in reticulocyte count also. Okay, so normal retic does not rule out a hemolytic anemia. Okay. So anything else?
So when Dr. Ankit asked what first to be done, was the answer for the post-results is one, to look for a peripheral smear and appropriately get from the central laboratory, discuss with the pathologist and see the smear. And second one is the Coombs test. These are the two simple tools which would have been done here. That's what Dr. Ankit conveyed.
Yes.
Further workup to know whether it's a primary autoimmune anemia, secondary autoimmune anemia, infective, whatever that we need to look into. And treatment part, Dr. Ankit has explained very beautifully. So first episode of AHA, how to manage, second episode, then how to prevent the relapses. That may not be current purview of the current discussion. So we may have to more CMS on that.
So what is the infection which can cause to AIH very frequently? Which is the common viral infection or bacterial infection can cause to AIH?
One of the PGs replied in the first point immediately when the case was presented.
Okay.
Which infection can present as hemolytic anemia?
Yes. Can present with viral infection very commonly. Okay. Can come with pneumonia also. Okay. No.
Mycoplasma.
Mycoplasma. So in that patient, the patient can come with fever, signs of pneumonia with hemolysis also. Generally, what happens? Most of the autoimmune hemolytic anemia like AIHA, warm AIHA, usually come once the infection episode is gone. Okay, but in cold AIHA or particularly mycoplasma induced AIHA, they can present together. So in that patient, as adding a azithromycin would be a very much helpful. That you should reduce the amount of bacteria which is triggering the development of antibody. Okay, so mycoplasma IgM you can also do if you're suspecting. Okay, and to find out whether it's a warm or cold antibody, you have to tell the pathologist or the lab person to do antibody testing at different temperatures. Okay, whether it's at a warm temperature or that is plus or minus 7 degree temperature, they will usually do of 37. Okay, and if patient is of cold AIHA, then you have to keep the room warm. You have to give the warm blood also. Okay, to prevent the further degree of hemolysis. Okay. So these are some practical points while managing the patient. We have one patient who is it turned out to be a very rare blood group disorder. We couldn't find a blood for that patient for 1.5 months. So we keep giving him immunosuppression AIHA. Consider it was a AIHA. He presented with AIHA, but patient has a rare blood group like Cafidal. So it was a very rare blood group antigen which was causing hemolytic anemia with any blood transfusion. So we couldn't get any blood for that patient. Patient was of head injury. It presented post-op to us with HB of 4. Okay, so we managed that patient on immunosuppression and we couldn't find blood. We have almost checked for more than 3,000 donors for typeable blood for that patient, but we couldn't find that. So in that patient, we have given IVIG, steroid, even rituximab we have given. So rare blood group mismatch can happen in some of the patients. It's very rare, but you can keep that in mind. Okay. But blood bank will check that it is compatible with all rare blood group also. If your blood bank is having all this equipment.
Sometimes we get a call from the postgraduates, severe anemia, not sure of the peripheral smear has been most people not seen and whom should have not ordered. They say that sir steroid देने से पहले bone marrow कर देना क्या? But if the clinical picture is very typical and you discuss with the pathologist, smear finding are very typical and whom turned out to be positive, I would definitely say no for the bone marrow. What will Dr. Ankit, your comments?
Yes, in this patient, I would not wait for a bone marrow. I would more focus on, and if you doubt, you will always have IVIG for safer side, which is safer a quick acting. It will not change the bone marrow picture, and you can, if you have a doubt, once the patient stabilizes, you can do a bone marrow. But in this patient with DCT, ICT positive, cola colored urine, I will definitely jump to giving a steroid. Okay, so. If
peripheral smear and Coombs will solve the controversy for us. If you have seen, discuss with the pathologist, relax, don't panic the family and don't panic yourself also. Give the steroid and save the life. Later on, if there is malignancy sitting inside, it will come out. It doesn't keep quiet.
We cannot say, we cannot be right at every point of time, but in 99% of cases of AIH, most of the time we are right. So we don't want to wait for a patient to get deteriorated, and we want to start even steroid immediately if facility of IVIG is not available. Okay. So what we do, we don't give pulse methylprednisolone in this. We give MPS, that is 4 milligram per kg per dose 6 hourly. Okay. What happens is sometimes this methylprednisolone give rise to hypertension in this patient, particularly when giving pulse methylprednisolone, that is 30 milligram per kg. So we give 4 to 8 milligram per kg per dose 6 hourly, depends. And we give for 72 hours. Once patient is get the blood, patient is being stabilized, we shift that patient to oral, but we continue that steroid for at least 3 months. Okay. We start tapering almost after 2 months and we'll stop around 3 months. And particularly in adolescent with AIH, you also have to work up for ANA or SLE workup. Okay, and if it is less than 1 year, that is very in infant, you have to go for other immunodeficiency like autoimmune lymphoproliferative syndrome. Okay, it is usually common in around 5 years of age. Okay.
And Dr. Ankit, what is your comments? Ki sometime when we send for a cross-match blood bank, the blood bank officer will say that sir वो positive दे देता हूँ आप लोग दे दीजिए. What is your comment on that? I'm
Yes,
audible, doctor?
no,
I'm
no,
audible?
no, your voice.
So sometimes when you send a cross match, there is no cross match. The postgraduates will ask कि वो positive दे देंगे under cover of steroid. So what is your comment on that? वो positive Paxil transfusion for a life saving under cover of steroid.
So particularly in this case, if whatever typeable blood or whatever blood is available for the patient, it is the best
Least
blood.
incompatible. Least incompatible.
Yeah. Okay. That is the blood bank has to decide. Okay, we are not the person to decide because they will check for the antibody and antigen antibody reaction in vitro also. Okay. So that is the base. And of course, you have to start steroid first and then you have to give the blood.
Steroid is always first. Yeah,
Because it is
absolutely.
the fast acting and it will take some time, particularly in patient of AIHA, to get the blood also. If it's getting very easily, that means that the titers are not that high. Okay. And you can always start steroid immediately and give the blood. That will stabilize patient immediately. Okay, then we can.
If no more comments, Dr. Vaishali, madam, shall we?
Yeah, I think we have had an extensive discussion, and really thanks to both you experts for this really lucid presentations and interactions. Thank you very much. I think Dr. Baldev sir also was there for most of it, but I think he had. Thank you once again. Thank you all.
Thank you very much.
Thank you, sir.
Thank you, Dr. Ankit. Thank you, Dr. Mahadev.